Thank you and good morning, everyone. And that's marvelous to hear about all of the accomplishments of the walk and all of the partners. And so I didn't know that. So thanks so much. It was great to have an opportunity to hear about that. So I'm a geriatrician. I'm not a neurologist or a psychiatrist, but I kind of play one on TV. So geriatricians are trained in internal medicine, so we're specialists, and we specialize in the care of older adults. So a lot of it is looking after chronic conditions that can be more common with aging. But many of those conditions do involve the brain. And so a lot of my practice is with regards to cognitive impairment or Alzheimer's and other types of dementia. But Parkinson's disease is one of those conditions that I see as well. It's a real privilege to speak to this group, and Mark told me that it's a very sophisticated and knowledgeable group. So I hope that there won't be too much review in here, and I hope that I can answer your questions if you have any, so please feel free to let them rip. And if I'm going over stuff that you already know, you can kind of give me the laissez les bon temps rouler sign, and I'll try to move on. But the topic we're going to focus on is anxiety in Parkinson's, and it really is different and requires a different approach if we try to help. So we'll do a brief overview of Parkinson's. We'll talk about anxiety in Parkinson's and what makes it different, and then we'll talk about what we can do to help, so treatment approaches that you might have experience with or might want to bring up to your healthcare providers. So this is Mr. Angelo Zayati. He's a sort of our sample case today, and he sometimes goes by Ange, so anxiety. Dr. Didyk, so funny. But he's 74, and he has been living with a Parkinson's diagnosis for about 6 years. His treatment, the mainstay of his treatment is levodopa-carbidopa, or carbidopa-levodopa. He's on 2 tablets 4 times a day, and that's working pretty well for his motor symptoms most of the time. He does belong to Rocksteady Boxing, and one of his main hobbies is stamp collecting. He's the president of the club. But there have been some changes over several months. A lot of fatigue, so more than usual, and just too tired to bother going to boxing class. He has lost weight. And his appetite is poor. But part of that is because of what he's feeling when it is mealtime. And he's actually canceling meetings of the Stamp Club, which isn't like him. When we explore why Ange is having these changes in his day-to-day function, he says he's feeling shaky. He's feeling shaky both inside and out. It's a different feeling than he's experienced before. He has a feeling of doom and panic at times, and these seem to be specific episodes of panic. His wife has some lorazepam on hand, which is a benzodiazepine, and he confesses to using one of those on occasion, and they are effective for quelling that episode, but it'll return later. He is much more fatigued, and that's leading him to take naps during the day. And part of that is that the shaking episodes are exhausting him, but also he's not sleeping well at night. He's consumed by worries and fears, and so he's napping in the daytime to kind of make up for that. So what's going on, and what should we do? So I'm the first speaker today, so I feel like I can do a little bit of basic review of Parkinson's. It's something that I see a lot in my work. It's the second most common neurodegenerative disorder in older adults after Alzheimer's. And it does affect 1 in 100 adults over the age of 60. In a younger age group, that number is much lower at about 0.3 per 100. But it certainly does affect people in a middle-aged and younger age group as well. Most of the time, it's what we would call sporadic, so there's usually not a genetic component. And there can be Parkinson's symptoms or Parkinsonism that's due to some other cause, like a stroke or medications sometimes. So that's not Parkinson's disease, but people can have symptoms that overlap with Parkinson's disease. And this is kind of like if we turn sideways and slice the brain like this. you would see, you can sort of see the part of the brain that's affected in Parkinson's. So it's the substantia nigra. And this nigrostriatal pathway, the dopamine, the neurons or the cells that release dopamine, which is a neurotransmitter or brain chemical, they degenerate. And so there's less dopamine going along this pathway to that blue area, which is what we call the basal ganglia, the putamen and the caudate. And so that area is, when that's affected, that can produce the symptoms of Parkinson's. So that's why most of the time our treatment for Parkinson's is aimed at boosting that dopamine. And the classic symptoms fall into a mnemonic. So in medicine, we love to make initials of things to mostly help us remember when we're writing exams. But and some of the mnemonics don't even make sense. I'll show you one later that I remember it, but it's meaningless. But the one for Parkinson's is TRAP. So T is for the tremor, which is a slow tremor, sometimes referred to as pill rolling. Usually it's asymmetric or often starts in an asymmetric way. R is the rigidity, which is the person will experience increased tone or more stiffness throughout the entire range of their motion or their movement. But then with that tremor on top of it, it can make sort of a ratcheting or cogwheel rigidity as it's described. And that can be painful and a symptom that's very problematic. We make bradykinesia into akinesia. So brady is slow, A is no movement. But we sometimes say akinesia to make it fit into our mnemonic, but that's the slowing. And oftentimes people notice slowing with their fine motor movements at first. So things like buttons and handwriting will change because the movement is slower. And P is for postural instability. So oftentimes I will see people who are having falls or feeling off balance, and when we do an examination and take a bit more history, it turns out that there's some Parkinson's symptoms there. So those are the cardinal symptoms. There are other motor symptoms too. So motor symptoms are kind of the movement symptoms, the symptoms that involve, the skeletal system and the muscles. People can notice changes in their voice and swallowing. There can be changes in vision and smell as well. So things you might not think of when you think of Parkinson's. People can have changes in their posture. Leaning forward is kind of classic, but also leaning off to the side can be seen. People will report having trouble turning over in bed. So these are all questions that a physician or nurse practitioner might ask about, or a therapist if they're thinking about symptoms of Parkinson's. And we always want to see how somebody is walking, if that's how they get around, is by walking. Because the changes that we see in the way the person's walking are often very helpful in making a diagnosis of Parkinson's. So you'll hear people saying that the person is shuffling. Really what it is the steps are not as high up off the ground. The stride length is usually shorter, so steps are smaller. And the person has sort of less coordination and ease of movement. So when the person turns around, it might be harder to do a pivot turn, and the person might kind of turn by degrees. It's called en bloc turning. So there's all of those motor symptoms that we think of with Parkinson's, but there are non-motor symptoms as well. So symptoms that don't involve movement. And those can be very common and very, very problematic to a person's life. They can really affect function. There is a Parkinson's disease dementia. It looks a lot like Alzheimer's in terms of effects on short-term memory and executive function and visuospatial orientation and so on. And that can occur in up to 40% of people who are living with Parkinson's. It's usually later on in the course of a Parkinson's diagnosis, and it's treated in a very similar way to Alzheimer's. People can get psychosis, so they can have hallucinations. That can be part of another type of dementia that overlaps with Parkinson's symptoms. That's called dementia with Lewy bodies. So that's something that you might hear about if a person is living with Parkinson's and has some cognitive impairment. Somebody might say, well, what about dementia with Lewy bodies? And that always, almost always has some very vivid hallucinations associated with it. But that can be a side effect of dopamine as well, if a person has too much dopamine. Parkinson's can affect sleep, it can cause fatigue, it can cause autonomic dysfunction, which is a change in the autonomic nervous system, and it sounds like automatic, and that's a good way to kind of think of it because it controls a lot of the things that are important for day-to-day life, but we don't really think about them. So things like breathing and maintaining our blood pressure and, only urinating when we want to and things like that. So autonomic dysfunction can show up with some of those symptoms that are listed there. And a common one is that blood pressure drops when a person stands up, and that can lead to falls and dizziness and so on. And there's even some skin changes that can go along with Parkinson's. But the one we're going to focus on today, the non-motor symptom that I'm going to talk about in a bit more detail, is the mood changes that can happen with Parkinson's. And when we talk about mood, it usually involves how a person's feeling and their behavior. And that can lead to us diagnosing things like depression or anxiety, or sometimes even if they don't meet a full-blown syndrome, they might just have those symptoms. So that can include things like apathy or loss of interest, or what we call anhedonia, which is a loss of pleasure. So let's talk a little bit more about those mood symptoms. Depression and anxiety, and I'll talk about them a little bit in the same breath, they really do go hand in hand. And that's true of people living with Parkinson's and the general population. Depression and anxiety, though, are the most common psychiatric symptoms in Parkinson's, and anxiety symptoms are present in up to half of people living with Parkinson's at some point. There's a difference between anxiety symptoms and an anxiety disorder. So same thing with depression. There's people who have depressive symptoms but don't meet criteria for a major depressive disorder. And that criteria is all written down in a big book. It's called the DSM-5, or Diagnostic and Statistic Manual. It's in its 5th version. And that's kind of the handbook that we use to help make psychiatric diagnoses. So usually it's kind of a checklist that we go through because we don't have really good tests to diagnose depression or anxiety, right? It's not like we can do a scan and say, oh yeah, the anxiety centers are firing. Or, the cortisol level is off the charts. They must have an anxiety disorder. So we really rely on those descriptions of behavior to make those diagnoses. So sometimes there's enough on that checklist that it meets the criteria for a disorder, but sometimes it's the symptoms, but not quite a full-blown disorder. And that can affect how useful our medication is going to be sometimes. So for example, in depression, if you have depressive symptoms, you're not as likely to benefit from an antidepressant as someone who actually has a major depressive disorder. So it is kind of important sometimes to tease that out. Anxiety, so we all have anxiety. I got anxious when I came up on this stage today, but it wasn't so much that it was debilitating for me. So the anxiety in Parkinson's or as part of a disorder has to be more than typical. And it has to get in the way of day-to-day function. So remember Ange, how he couldn't do his stamp course anymore. He couldn't do boxing. So because of his anxiety, he wasn't able to complete his functional tasks. It's tricky in Parkinson's, and we'll talk about some other reasons why, but a lot of the symptoms that for anxiety and depression can overlap with some of the symptoms of Parkinson's itself. So I think what we often look for is this a change from how things were before? And is it now getting in the way of day-to-day life? So a person living with Parkinson's might have fatigue, but it might not be to the point where they would cancel an activity. If it's part of their anxiety, then maybe they would cancel. And we'll talk about why it's important to screen for depression as well, because those two things often do go hand in hand. I didn't put the reference up here, but I can share it with Cassie. This was a survey of people living with Parkinson's and how many had anxiety symptoms and met criteria for anxiety disorders. So the anxiety disorders, there's generalized anxiety where a person's kind of worried all the time about everything. And then there's social phobia where someone is very inhibited to go out and eat a meal in public or do other things. Specific phobia is usually around some specific thing like spiders or heights or small spaces. And then panic is where people will have episodes of panic. They may be triggered by specific things or just come out of the blue. So you can see that generalized anxiety was most common, but there were other types of anxiety as well. And 30% of people kind of fell into more than one category. So it's common. And yeah, generalized anxiety, again, people worry about things that are legit to worry about, but it gets out of control. So it's really out of proportion to what they should worry. So you might worry about, okay, you know, what if I go to the mall and I have to pee and I don't know where the bathroom is? You know, that's something you might worry about. But if it's so debilitating that you know you're planning a trip to the mall and the day before you start fretting about this and then thinking about it, talking about it, can't sleep because of it, that could be an anxiety disorder. And the other symptoms, so again, this is part of that checklist in that manual. We would say, okay, well, is the person feeling restless? Are they hyper alert and vigilant? Are they tired? Are they irritable or cranky? Does it affect their concentration and sleep? And people can even feel muscle tension as part of their anxiety. So again, thinking about symptoms that can occur in Parkinson's, some of these, you know, we'd have to make sure that they're new, that they're a change from before, and that they're problematic and associated with anxiety. What makes Parkinson's and anxiety different? So about 10% of the population has, you know, anxiety disorders. Why might it be more common in Parkinson's, and what makes it different, and why would we maybe want to treat it a little differently? So there's two reasons. One is that the chemicals that are altered with that degeneration of that substantia nigra, dopamine is one of them, but there are other chemicals as well, like serotonin and norepinephrine, and we think of those as the mood chemicals, right? And dopamine is too. But those can degenerate as part of Parkinson's. And some people will even complain about, or that's a medical thing, you say the person's complaining about something. We're not complainers here, but you know, someone will report that they're having changes in mood or they're having anxiety, sometimes even before those motor symptoms come on. So that could be a very early finding in Parkinson's. So there's a chemical reason for it, but there can also be a reason that's related to the therapies that we use for Parkinson's. And that is that anxiety can be triggered by the wearing off of dopamine. So, and that's why it's often helpful to have somebody do a journal if they're having anxiety. So to keep track of that, when are we feeling anxiety? Does it relate to the dosing of the medication? You know, is there some kind of a relationship there? So there could be, and somebody could have both of these things, and that's why they're having anxiety. So it is different in Parkinson's. So the anxiety that happens with wearing off, and wearing off is one of the motor fluctuations that you might have heard about. So it's kind of a side effect or I guess complication of Parkinson's and Parkinson's therapy. So as people, you know, like Ange is taking his dopamine 4 times a day, but as he's getting to the end of that dose interval, the chemical kind of wears off. And so Parkinson's symptoms might reemerge at that time, and that can be associated with anxiety. So it could be a wearing off. It could also be sometimes there are just unpredictable off periods. So you just took your dose and there's an off period an hour later. There can be motor off symptoms. Sometimes people just don't ever get an on symptom. Or even acute akinesia, which is very dramatic. Usually a person almost seems like they are catatonic, great deal of difficulty with movement, and thankfully that's extremely rare, but it's important to be able to diagnose it, and usually it just involves, you know, continuing with the treatment of the dopamine and increasing it, and it'll eventually get better. So wearing off is one of those motor fluctuations, and they can be pretty common in Parkinson's. So if we're seeing that pattern, if we're seeing that worry, we're seeing that anxiety, It might even meet criteria for an anxiety disorder. What's our next step? So we do want to screen for depression because that can go along with it. Depression is a loss of pleasure, it could be sadness, but it could also just be not caring anymore. So somebody might not necessarily be sad and crying and expressing depression the way we might classically think of it. And here's this mnemonic that makes no sense but is somehow memorable, SIGI CAPS. If anybody knows what a SIGI CAPS is, please tell me, but it's just something that we remember. So these are all the other symptoms that can happen with depression. And in addition to a persistent low mood or loss of interest, we want to see 5 of these things on this list. So a sleep disturbance, often more sleep or less sleep, usually having trouble sleeping in the morning. Loss of interest, feeling excessive guilt. Changes in energy, usually low energy, trouble concentrating. Changes in appetite, which can be less or more. Usually it's a loss of appetite. People can get slowed down because of depression. So people can can have slowing that can, even make us wonder about Parkinson's if they're severely depressed. They can just be, slow to, answer questions or to move. It's quite remarkable to see. And we always want to screen for suicidality as well. That's because people who are depressed are at higher risk of that. So now we want to talk about treatment. When there's this anxiety, this problematic anxiety, what are our treatment approaches? And I'll show you a little tree. In medicine, we love to have we call them algorithms, right? So that we can go through and decide, oh, let's try this. That didn't work. Okay, well, what's next on our branch, right? But there are challenges when it comes to the treatment of anxiety in Parkinson's. Because of those 2 different modalities I mentioned, so it could be because of chemical changes, it could be because of medication side effect. We have to think about both of those things when we're treating. So we might not just want to adjust one of those parameters or the other. Being a geriatrician, I like to change one drug at a time, if I can help it. But we don't want to just say, let's start an antidepressant and then walk away. We want to also think, okay, well, maybe at some point we want to look at dopamine as well. So we might not just want to adjust Parkinson's meds or just give an antidepressant. We have to think about both. So the mainstay of treatment for anxiety, just in older adults in general, is to use an anti-anxiety antidepressant or anxiolytic antidepressant. So probably the most common family of those is our SSRIs, or selective serotonin reuptake inhibitors. So they increase the amount of serotonin in the brain, and that seems to help with anxiety. And those can have side effects as well. So in older adults, any antidepressant will increase the risk of falls. They can worsen some of those autonomic symptoms like incontinence or diarrhea or constipation or orthostatic low blood pressure. So the antidepressants are the mainstay. They're not perfect, but we do use them a lot in older adults. The other mainstay of anxiety treatment are the benzodiazepines. So that lorazepam that Ange was kind of cadging off of his wife to see if it would help, it did. And that's because it's a benzodiazepine. So benzodiazepines, or the PAMs, they're sort of this family of drugs that usually end in PAM. So you might have heard of Valium, which is diazepam. Ativan is another one, lorazepam. All these PAMs are in a family called sedative hypnotics. So a lot of times people take them to help with sleep. They're used a lot in anesthesia because they do help to relax a person, and they also induce a little bit of amnesia. So if you get a dose of midazolam, which is a LAM, not a PAM, but it's a benzo, if you get that before your colonoscopy, you might not really remember all the details of your colonoscopy, right? You remember, I was lying there and I saw the screen and it looks like a circle, and there was water, and then I woke up. So they can induce amnesia. So they will, I mean, it's like they just lice your anxiety, right? You know, it just kind of bursts that anxiety bubble in the moment. But the PAMs have a lot of side effects, and they can be especially troublesome in older adults and older adults living with Parkinson's. So the PAMs can cause fatigue because they're sedatives. They can increase the risk of falling, and they can even, some of the longer acting PAMs, like clonazepam, they can actually increase the risk of breaking a hip in older adults. So, you know, they do a lovely job of busting your anxiety bubble, but they have side effects. And they don't last forever either. So antidepressants, or the SSRIs, they kind of build up a level in your blood, and you know, eventually your anxiety symptoms can improve, or your depression can improve. Benzodiazepines, once they wear off, they're gone. It's kind of how I think of them. So that's a challenge, to use the benzodiazepines. We definitely don't want to use high doses of them, and we don't want to use them indefinitely. When I show you my little algorithm of how we should treat anxiety in Parkinson's, it starts with non-medication treatments. And I'm a big fan of non-medication treatments. Sophia's going to talk about non-medication treatments after me. Sophia Christopher's a music therapist. So I bet the music therapy has a lot shorter list of side effects than benzodiazepines do. But those treatments can be hard to get, and they're often not covered. So, you know, and there are lots of system issues and reasons for that. But that can be a barrier to implementing the non-medication treatments that would be helpful and would have so many beneficial side effects rather than negative side effects. So I don't want to be a negative Nicole about those, but you know, there are issues that can be very real for people. That's why it is actually really wonderful to have organizations like the Parkinson Society, because oftentimes those programs can be delivered in a more efficient and economic way and be subsidized. So I really appreciate it when there are programs like that. I do need to tell you that what I'm talking about, there's not a lot of evidence for it. So I did find a very good recent review by a geriatric psychiatrist at Cedars-Sinai Hospital in the U.S. And we're thankful that there are some trials for depression in Parkinson's. So we do have some good evidence that there are some antidepressants that seem to help with the depressive symptoms in Parkinson's. So those are medications that I've put on the slide there: venlafaxine or Effexor, and paroxetine or Paxil. Those have demonstrated efficacy in depression. So that's good, but they didn't seem to help with the anxiety symptoms, or the anxiety sort of subsets that were studied in those trials. So the one big trial of the antidepressants was the SAD-PD, SAD-PD. Of course, it's got a mnemonic associated with it. So we don't really know which anxiety medications work well for the anxiety of Parkinson's. So we approximate as best we can, and we say, well, let's treat as we would for if it's an older adult, let's just treat as we would any anxiety disorder, and hope that we get more information about which medications are best. The non-medication treatments that I mentioned, and I'm sure that many of you are experts in some of these, much more than I am, but I will mention them here because there are some trials looking at the efficacy of these treatments. So cognitive behavioral therapy, there does seem to be some evidence that can help with anxiety. And that's sort of learning techniques, ways to recognize anxiety symptoms, and kind of techniques you can use with your brain and self-talk and other tools to bring that anxiety down. And usually medication works better when it's done in conjunction with cognitive behavioral therapy. There's a large trial currently with the Michael J. Fox Foundation with mindfulness-based stress reduction. So Again, that's kind of overlaps a bit with cognitive behavioral therapy. There's some meditation and other techniques associated with that. And then there's some evidence that the non-invasive brain stimulation can help with anxiety and depression. So again, I don't have expertise in those. I wouldn't prescribe or administer those particular treatments. But if I had someone who was struggling with our other approaches, I would refer them on to see if that might be helpful. Deep brain stimulation also, there didn't seem to be significant improvement in anxiety with deep brain stimulation, although it can be efficacious for other symptoms of Parkinson's, but that's not something I would probably recommend just for anxiety. So from a practical point of view, we would try to get as many of those non-pharmacologic treatments as we could, or non-medication treatments, and then we would look at how to treat we might start an antidepressant and then look at the dopamine pathway to see if we could make changes. And that kind of involves two main approaches. One is adjusting the medication, and the other is dietary adjustments, which again, I'm sure many of you have a lot of experience with. So the dopaminergic medication adjustment, it can be a lot of trial and error, but it could involve smaller, more frequent doses, switching to a slower release or extended release formula instead of a shorter release or intermediate release preparation, and then adding another medication to enhance the dopamine. So those are all things that your neurologist or geriatrician or family physician who's ever managing the Parkinson's medications could try. The dietary changes, now, we have to be careful with these because remember Ange, our fellow there, he was losing weight. And part of that was that he was struggling with trying to time his Parkinson's medications and his meals. But in general, if a person who's taking L-Dopa is able to avoid protein when taking a dose, or just try to take a dose on an empty stomach, sometimes that can boost the bioavailability of the dopamine. It also appears that H. pylori, which you might have heard of in association with peptic ulcer disease, so that's the bacteria that is in our stomach, and maybe Dr. Rojas can speak to that. But it does appear that if that is present and treated, that might help with absorption of dopamine as well, or L-Dopa. So here's my super busy algorithm slide, and hopefully you can read that. But basically, and this is from Dr. Pontone, again, from 2020. I found this article very helpful. It was in the American Journal of Geriatric Psychiatry, I believe. Basically, so those special cases I'll just skip over first. They're kind of down at the bottom in those blue rectangles. But the start of our approach to anxiety would be to encourage activity, to encourage exercise, and of course that that exercise always has all those other side benefits of promoting distraction, helping a person sleep, helping their bowels to move better, all of those things. It could help if there's depressive symptoms as well. And then probably the next step would be, the tier 1 step would be to try a medication for anxiety, as well as, thank you. Oh, is that who's mousing over my, thank you, wow, you're paying attention, woohoo. And then the bottom square there is trying those other things like CBT, mindfulness, and that. If that fails, then we might want to consider adding the benzodiazepines, so our beloved PAMs, or another thing that might enhance the antidepressant is buspirone, which is another psychiatric medication that we might add on. So we basically just, if the first tier 1 kind of fails, then we go to more elaborate or more enhanced kind of medications. If that fails, we might want to consider if there's something else going on, and you can do that at the get-go if you're noticing one of these patterns, or you can wait until the therapy has failed and say, well, what am I missing? So the other things to think about that kind of makes anxiety and Parkinson's different is Is it medication related? So do we need to adjust our dopamine medications in addition to the other things we're doing? Is the anxiety associated with a fear of falling? So I haven't really talked about that, but that's a very common phenomenon that can happen with people who are falling, whether they're living with Parkinson's or something else. But it can become debilitating to worry and traumatizing, almost like a post-traumatic stress. If a person has a fall, they're really afraid of that happening again. So that might need to be addressed. Is the person living with dementia? So dementia can produce anxiety as well. So all of those changes, mind chemical changes that can happen in Parkinson's can happen in dementia disorders as well. So that might be something to screen for if our treatments don't seem to be working. And then autonomic related symptoms, so maybe that's why a person is having panic or feeling worried. Are they having autonomic episodes? That's something else to think about. So this is a good little algorithm. Again, it's based on the best evidence that we have. And I should mention that, for the fear of falling, occupational therapy and physiotherapy can be very helpful too for my colleagues over there from occupational therapy. So this algorithm is, thank you for the 5-minute notice, and I promise I'm gonna I'll get out of here. It's based on the best evidence that we have, which is scant in some areas, but I think it's very reasonable, and I appreciate that it's stepwise and that it does involve looking at other things that make that make anxiety and depression and Parkinson's different. I do want to say too that care partners are really instrumental in the treatment of anxiety and depression. Yeah, because care partners can help to recognize those symptoms. When I see someone in my clinic, I always ask that they bring a person in their life who knows them and who can narc on them, who can report what they're noticing. Because oftentimes we don't notice symptoms ourselves. That could just be, because sometimes we just aren't that self-aware, or it could be a symptom of the condition, the brain condition that affects our insight. So care partners, please do share when you're noticing changes, because they might not just be a normal part of a person's condition. They might be something additional that we can address. And help is available. And sometimes it does take some advocacy, to say, well, this isn't normal. This is a change. Those kinds of phrases get my attention if I hear that it's different. And so please do remember that your role is so important. So anxiety, I'm still kind of proud of that. So he was diagnosed with an anxiety disorder, and he had panic along with it. And so we did some non-pharmacologic things. We looked at his sleep. We gave him a sleep hygiene program. We told him to stop napping. And he was put on an SSRI, or sertraline or Zoloft. And those take a while to get up to a good dose and to get in the bloodstream, but they did seem to help after 6 weeks. He was keeping a symptom journal, and he noticed that his panic was happening as his dopamine dose was wearing off, so we changed that formulation as well. And this, of course, is a fake case, because within 2 months he was better. But you know what? People do get better. I mean, it's often he'd get better after he's tried his, second antidepressant, and he's found the right therapist, and, other things like that. So it's not so simple as this suggests, but for sure there are things we can do when anxiety comes about. So those are all my slides. I think there might be a few minutes for questions, or maybe you can save them. Thank you. I'll leave that.